So welcome everybody. Thank you for being here on a Friday, and thanks for folks that have made a choice to log in to watch this presentation. We really appreciate your interest in this important topic. So my name is Nicole Poulin. I'm the Executive Director of the Family and Children's Trust of Virginia, or FACT of Virginia. We were established by the General Assembly in 1986 to focus on supporting programs and efforts throughout the Commonwealth of Virginia that are focused on treating and preventing child abuse and family violence. It's a pretty big scope that we have, but we are a small but mighty team, is what I say. So the Family and Children's Trust Fund does that through funding individual services in localities, raising awareness, and doing research on different issues related to child abuse, neglect, and family violence, and also providing advice on policy relating to these matters. So kind of under that purview, one of the things we do is we coordinate the Child Neglect and Abuse Committee for Virginia, which is one of 3 advisory committees established by requirement from the federal government for funding. It's a block grant that the federal government provides. And that committee is focused on really examining issues related to child welfare. Through the work of that committee, this issue of problematic sexual behavior kind of came to our attention a few years ago. I feel like we've been working on this project for a very long time. And during that work, we kind of determined that this is an issue that within Virginia, but also nationally, is one that everybody is kind of grappling with. And we're specifically focused on younger children who are exhibiting problematic sexual behavior against other children. And the challenge from a systemic perspective is it's a jurisdictional issue. So Child Protective Services has jurisdiction when there's abuse or neglect from a caretaker, and law enforcement has jurisdiction over all other types of relationships in that type of environment. And so this issue, what we're really talking about is those cases that fall between the cracks. So if you have a child that's exhibiting this behavior to another child that is not in a caretaking role, who provides those services, who addresses that issue? And Nancy's going to talk about the complexities about that, but this is something that came up and we continue to grapple with. So the committee and the FACT Board of Trustees made a choice and a wonderful decision a few years ago to support hiring a contractor with expertise, and we could not have found a better one than Nancy. And so her work, she's about to go over that, is basically guidance and recommendations around how communities and how the state could respond to this issue to be more effective in handling it. So that is why we're all here today. So she's going to be going over that, her research. The research is available on our website. As I mentioned, this recording will be available on our website. And I think that there's strong potential that the FACT Board may be interested in investing in partnership with another program, potentially another state agency in Virginia, a second phase of this project to develop a kind of more expansive reach of it through training and awareness. I want to make sure I also mention that this project was conducted in partnership with the Virginia Department of Health. They've been very supportive of this work, and we want to thank them. So without further waiting, just a really quick technical detail. What I think we'd like to do is have Nancy go through her presentation. Folks, feel free to put questions in the chat. I'll try and monitor that. And at the end of her presentation, she's left time for her response to questions that are posed. And I think we have a small enough group so that at the end, if we don't have a lot of questions in the chat, folks can maybe raise their little virtual hands and we can actually speak with one another. Nancy, is that okay with you?
That's perfect.
Okay. All right. Now we are also going to give fair warning that we're having some technical challenges this afternoon. And so I'm going to be sharing my screen because Nancy hasn't been able to access that feature on this virtual venue. So bear with me. Can you all see that?
No. Yes, maybe. There we go.
Excellent. We good? Can you see that?
Yep. Perfect.
Do you want, can you see the notes?
Yeah, I don't need the notes. If you want to just go into the next slide, that'll be perfect. Okay, so I'm going to go through this and go through it pretty quickly, but obviously I would love at the end to hear any thoughts and questions you have. I'll tell you that this was quite an undertaking of a project that when we discussed it in theory, it sounded like, okay, this is something that is I can wrap my head around. And then the more and more I got into it, the more complex I realized the issue was, and that was probably because of my own naivety. I have a background as a prosecutor, and so I've obviously been around this issue for many, many years, but trying to take it out of that criminal justice perspective and look at it as a community response was challenging. But just so you know, for the purposes of this discussion, you can see on the screen the definition that I adopted for problematic sexual behavior, and that was based on the National Children's Alliance definition, that we're speaking of children 12 and under only. And we're focusing on problematic sexual behavior that is exhibited towards other children, because that's when that usually triggers a report into the community. And so that's kind of the framework for everything. You can go to the next slide. The other thing too, when we're talking about problematic sexual behavior, we're looking at these other characteristics usually as well. And so there's more content in the actual full document, but I think it's really important that everyone involved understand kind of what is and isn't problematic sexual behavior in children. I'm sure most of the folks on this call have a good grasp of that, but as we broaden the response into the community, into law enforcement and just other community partners, I think that part of an effective response is being very specific of what is problematic and what is not problematic. One of the things that I think also has to be reinforced is that when we're talking about a child exhibiting problematic sexual behavior, we're usually talking about children who have in some way been asked or told to stop their behavior and still continue it in some format. You go to the next slide. Why did we look at just children 12 and under? One, because I think that we are all seeing across the country an acceptance that there is a brain development issue that has not properly been acknowledged in the juvenile justice world. Now that obviously goes much greater into your early 20s, really, and people are grappling, okay, with older juveniles, how do we use that? What do we do with it? But in this process, I think we're moving away from this idea that children of 9, 10, 11, and even 12 really belong in the criminal justice system, except under extreme situations. And so that's the first piece of this, that 12 seems to be a comfortable line to draw. Most professionals are very comfortable with this line at 12 and under. I'll tell you, the criminal justice world is not as comfortable with 12 being that age as maybe some other disciplines, but I think we're all moving in that direction. And so I think the more research that can be offered and the more education done, the more the criminal justice system, I think, will fall into this category as well, of people saying, okay, this is a good place to draw this line and not look at children 12 and under as a first response to issues being the criminal justice system. The second is that go back one more, I'm sorry, that treatment works. And that's a reason that especially the research around children this age, when there is appropriate response to children who exhibit problematic sexual behavior is given, they do not pose a long-term risk for committing future child sexual abuse. And that is, I think, something that has to be stressed over and over again, because historically, if without understanding that research, there is, I think, unfortunately, a default that they're the same as adult sex offenders and they need to be labeled and there need to be, the community needs to be protected. And we see something very different when we look at the research. Now you go. Also, too, The clinical assessment and treatment models were beyond the scope of my project. There is a little bit about what is nationally recognized in the full document, but this was more about how do we get the community to a point to get children to a proper clinical assessment and treatment. And so we do talk about screening assessment needing to be comprehensive. It needs to be specific to the child and the family, not just a boilerplate assessment. And there has to be a safety plan component of that as well. The other thing I'll just throw out there, even though I'm not going into treatment models, is that what the research tells us is that treatment does not have to be lengthy or necessarily remove a child from their environment in order to be effective, which I think is also something that a lot of professionals, especially in the criminal justice community, have defaulted to this idea of we have to remove the child, there has to be inpatient treatment. And that is not what the research bears out either. Next slide. So we have an issue because we don't know what the current extent of problematic sexual behavior is in Virginia. We don't have any consistent tracking of this in a way to determine what is actually occurring. Many agencies and community partners don't track the number of reports at all. Those that do track them don't always track them based on children 12 and under and children over 12. And it is just when I started looking at the different agencies, there is no consistent way that these numbers of these cases are being kept. So one of the things I'll talk about in the solutions, one of the foundational changes that has to happen is there needs to be some way to become consistent in tracking these cases so that we have an idea of what we're dealing with. Next slide. Law enforcement does track cases that are referred to them, but again, varies very differently from department to department into what they're classifying it. Often they're classifying these as allegations of sexual offenses. They're not differentiating in any way when they are a child of a certain age. Local CPS departments don't track these cases at all either because it's not under their mandate of response. The only way CPS would track any of these is if it also included a report of a lack of supervision by a parent or guardian. And even at that point, they're not being tracked as problematic sexual behavior cases that have lack of supervision. That lack of supervision is falling into a bigger category of parental neglect. So that is not an area where we're getting good numbers. And then the CACs are beginning to track cases, but they're basing their numbers, of course, on cases that they receive referrals for. They're not a place that, in most situations, community members are picking up the phone and making reports to. That's usually law enforcement or CPS. And so the two biggest conduits for receiving reports are not effectively tracking those numbers. Next slide.
Nancy, could you just, CACs are Child Advocacy Centers for
yes.
folks that might not know the acronym. And CPS is Child Protective Services.
Yes.
For the civilians.
Perfect. Next slide. I just want to touch on this. I go into it more in the full document, but a common misconception is that children that exhibit problematic sexual behavior have been victims of sexual abuse themselves. The research is split on this. Some research says that yes, there is a correlation. Others say that is not a correlation. And so what I think is important is that we have to consider that as a possibility, but we don't have to build our response around that as an assumption. And there is some good models out there on the national level that are looking at ways for when referrals are made to child advocacy centers, when you do and don't do forensic interviews of children to explore this possibility. And again, that's discussed more in the full document, but I think it's important just to put out there that is not always the case, that a child who exhibits this behavior has been a victim of sexual abuse themselves. Next slide. When we look across the state, and this is in no way meant to be exhaustive of everything you see, there are some promising responses at the community level to problematic sexual behavior. There's some consistency in those responses that is, I think, what any response we do build in Virginia needs to also include. And that is one that when we come across these cases that we are doing safety assessments, especially when there's intrafamilial cases, that there is appropriate treatment available to children because of the success of intervention. And that we do look at this as a community specific response when possible. I do believe there has to be a state umbrella. I'll elaborate on that in a few minutes, but I think that the key response has to be done by the communities and the multidisciplinary teams within those communities to be successful. The other part of it that I think is important is that we stay away from all stigmatizing terms that would imply that this is criminal behavior. So sex offender, juvenile delinquent, those terms should not be part of the professional vocabulary when we're talking about this response, that we truly are looking at children who need intervention, not people who've committed crimes and need punishment. Next slide. What we see in Virginia now, an example would be is a court system response. Some of this is triggered by a criminal charge being brought in some jurisdictions, but then a quick movement over to the court system looking at it as a child in need of services CHINS petition. So this is where I think if we had another alternative, this part would probably drop off. But there are jurisdictions out there that say, yes, law enforcement, I want you to get a petition so I can get it into court. I can then ask the court to either appoint guardian ad litem or even other key components of this. Let's get a CHINS petition in front of the court and then drop off the criminal charge altogether. CHINS is a good alternative because it does open up extra funding through the Child Services Act because it will trigger foster care prevention. And so that is a way a lot of communities are using the way to get into access funding in these cases. Next slide. We do see a lot of our child advocacy centers also trying to fill some gaps across the state. Some of them have therapists on site that are trained to respond in these cases. Others are doing pilot projects. For example, the Greater Richmond SCAN CAC is doing a boundary assessment project, which is an education project for kids that are referred and families that are referred in this area. The Davis Child Advocacy Center in Chesterfield has a good written protocol of what happens when any MDT member thinks that there's a situation of problematic sexual behavior. They do a screening format of when they should or should not be using forensic interviews to explore the possibility of abuse behind that situation. And they also do a really good job of making sure that there are no constitutional exposures for the child that exhibited problematic sexual behavior, in the sense that they do a really good assessment of, are there any possibility that this child is going to be charged criminally? And if there is, let's not put them at risk of being involved in a situation where they're making disclosures or other communications that may be constitutionally inappropriate to be made because they have a Fifth Amendment right against self-incrimination. And so they have a good model that looks at those issues. Next slide. When I looked across the state for barriers, it really put them into 5 categories. One is there's a lack of consistency from jurisdiction to jurisdiction. Often there's a lack of collaboration among community partners. There's a lack of training, a lack of resources, and a lack of ownership of the issue. Next slide. The lack of consistency, I think, is underpinned by the fact that we have no statewide guidelines or protocols for agencies to point to and say, this is what we should be doing. There are national models. I included a lot of that in our document, but without them being specific to Virginia and the nuances that we see both in our communities and in our code, they're not comprehensively impactful. And so that breeds a lack of consistency. Next slide. Lack of collaboration. Again, it depends on the community, how well people are working together. We do have a multidisciplinary team statute in Virginia. I'll talk more about why that's limiting in a minute. But even with knowing we have that statute, there are jurisdictions that don't follow even the bare minimum. And so we see, again, very different responses from the jurisdiction to jurisdiction to jurisdiction. Next slide. Our multidisciplinary team model is a good place to start, but our MDT team statute is not specific to problematic sexual behavior. And so that would need to be a fundamental change, I believe, in order for these teams to start being consistent throughout the state in this response. Lack of training is the next slide. There is no mandated training around problematic sexual behavior for law enforcement, prosecutors, or child protective services. These allied professionals are coming into contact with these cases regularly because referrals often come to them. And without proper training and the understanding of the research, there is a risk that the default is to, again, seeing these cases as similar to adult sex offenders. And when that leap is made or that conclusion is drawn, bad decisions follow. So the lack of training in the appropriate response to these cases is a problem throughout the state. Next problem is lack of resources. I probably don't have to tell anybody on this call about how much Virginia is struggling with resources to effectively respond to all forms of child maltreatment and abuse, not just problematic sexual behavior, but clearly the lack of resources, especially in rural jurisdictions and certain pockets of the state, especially. These lack of resources also carry over into this area as well. And then lack of ownership is my last issue. And that is because, again, there is no statewide entity that takes the lead in this. And so there's no consistent place where people should be calling to say, hey, I have this issue, or I know of a child that has this issue, or my child has been victimized in this issue. And so it's these reports are coming in different places, and then people are getting told different things when those reports are made. And so there is no statewide agency that takes ownership over the problem. Next slide. Which leads me into kind of, okay, what do we do? What are the solutions? And next slide would be a solution to the lack of consistency, which is it is unclear how many cases we have. And then the next problem, if you can go ahead and fill out the slide for me, is that we have, again, jurisdiction to jurisdiction, very different responses. My proposed solution to that, based on my total look at the situation, next button, would be to establish a statewide task force that would develop a model policy to guide agencies to respond in this area. With that task force, I think there's some things that should have to happen. There would have to be a statewide agreement of the definition of problematic sexual behavior. There should be some foundational mission type proposal based on the research of what that we should be looking at intervention and treatment and not a criminal justice response for this age group. That task force should be looking at a way to track data comprehensively and consistently. It should also be determining the best assessment methods for the initial screening, as well as then taking that next step of looking at appropriate treatment. And then there should be guiding principles around that multidisciplinary response to this issue, to give guidance to law enforcement, to give guidance to child protective services, to give guidance to the CACs as to what each community member's role should be in this area. Next slide. The problem with lack of collaboration, again, is that lack of interagency communication and coordination. My proposed solution to that would be, if you could hit the next button. The first part would be to revise Virginia's current law on multidisciplinary teams. Our statute right now specifically mandates there be reviews around felony sexual offenses and does not mention anything to do with problematic sexual behavior. So that statute should be amended to specifically delineate that problematic sexual behavior is not the same as felony sexual offenses or felony charges. There should be some more teeth within our multidisciplinary team statute that had some specific timeframes for case review, not only at the initial review of the case, but if a case has not been resolved. And it should have some accountability if jurisdictions are not using the MDT team approach at all. And one of those suggestions would be that right now the MDT team says it is to be formed and run by the prosecutor's office. There, I think, should be an alternative part of the statute put into place that if for whatever reason the CA's office is not doing that, then this team can be brought together and run by law enforcement. And that either of those agencies can then designate to the Child Advocacy Center as the actual team leader, so to speak, and that often happens. And so that's, again, very specific response, but I think our MDT statute is a good start, but has to have some teeth to it. The next solution would be to deal with the lack of training issue. And one solution would be to create a Virginia train the trainer model, which would then help jurisdictions hopefully develop their own resources. So there could be if you want to hit the next couple of buttons, we'll get to that. This will help jurisdictions. We'll have a statewide training that then jurisdictions can send their own team members to, that then they can learn a proper training around the research in this area to then take back to their localities and train their own professionals, so that we are getting out that information on the research behind appropriate intervention for children with problematic sexual behavior, especially emphasizing the fact that intervention and treatment and education is very successful. In addition, I believe that we should have, as a proposed solution, an NDT toolkit developed, whether that's done by a consultant or done by this state response, statewide team, so to speak, that gives that community some, again, guidance in how they should be functioning as a team within their own community, and who has each individual role depending on what their discipline is. And then the last proposed solution around training would be to make sure our judges are also trained. So working with the Office of the Executive Secretary to make sure that all Virginia judges who come into contact with cases of children exhibiting problematic sexual behavior also understand the research behind these cases and what is appropriate intervention. As far as resources go, this is where, it was one of those things that I don't have any magic solution by any stretch of imagination, but my overarching solution would be that we prioritize funding for child advocacy centers. The next part of that problem is not only just treatment providers, but if you can hit the next button, it's also that we all of our agencies, all of our team players are experiencing unprecedented shortages right now. So it's not just a matter of treatment, it's also a matter of these agencies being understaffed as well. Where I think a good way to spend our money would be, though, and that solution would be in that funding of child advocacy centers. Because if we can get those CACs funded and statewide, they are, what we have seen in jurisdictions with child advocacy centers is better multidisciplinary team responses. And so when if we can see that direct result in a community, we get a CAC in place, that then kind of makes the MDT model foundational for that community. That then enables everyone to do their job better. And then I have statistics within the document that would support that as well. And then finally, when we're talking about lack of ownership, I'm going to take a sip of water here. I proposed different models for ownership, so to speak, of this problem. The first proposition was a CPS model. And if you get it the next part, Nicole, that would be great. And just go one more for me. This is that the CPS would be the lead agency to take the intake reports, to provide assessment to families, and then to kind of farm out cases to appropriate treatment providers, depending on the assessment of those families. This was based on mainly the state of Missouri's response, and they have had great success by changing their code to make their Child Protective Services agency the appropriate agency to respond to the intake and assessment of these cases. And so I think this is a part of the solution for several reasons. I'll just hit on a few. One, CPS workers are familiar with conducting family assessments. This would, of course, require a development of a different type of assessment tool. It would require extensive training. It would require substantial funding and staffing. And it would require a change to the Virginia Code. But Child Protective Services is at least already up in place across the state so that we could use that model to be consistent. It would require, I think, more of an umbrella type model of CPS and having a state leadership, however, not be driven by the locality. So again, that's going to require a big change in the Virginia Code. And so there is no direct correlation between our CPS setup currently and what we saw in Missouri that is run at that state level. So this is a proposed solution with many acknowledgments of some challenges that we would face with this model. The next possible solution would be a court-driven model. And that would be basically the idea that we would enable the intake process into the court system to be better equipped to deal with problematic sexual behavior and to better allow different community members to access this CHIN's petition availability much easier than it is for them to do now. I think the CHIN's statute would have to also be changed to be specific about problematic sexual behavior. I do believe the way it is structured now technically would include problematic sexual behavior, but it lends to confusion because it does not specifically refer to PSB. So an effective model response would be a change in code, a change in intake procedures, and then extensive training, you would have to develop an assessment tool, and then we would still be needing to figure out where the appropriate treatment would lie in the community. The third model of response would be a child advocacy center driven model. This would be positive in the sense that many child advocacy centers are the ones kind of filling the gap for their community right now. But like the other two models, need increased funding, need increased staffing. It would require that MDT statute to have teeth to it because this would definitely require multidisciplinary teams to work appropriately in the community. And we still would be dependent on community partners to provide treatment options. Which then leads me to my final solution, which is by far the most expensive, by far would take the most time to put into place, but in my opinion would be the most comprehensive and then the big picture, the most successful, which is a hybrid model. It would require CPS to be, again, that statute change for them to then be in charge of intake. Basically, if a PSB is reported, the referral goes to Child Protective Services, and they then go out and do the assessment of the situation within the family. Once that assessment is done, law enforcement and prosecutor's office would have to make a decision. Is this a scenario where we are possibly pursuing criminal charges? And if we are, that takes the first step before anything else happens, so that that child involved would not have any of their constitutional rights trampled on. And then if law enforcement and prosecutor's office say, you know what, because of this age and the situation, we do not feel this is appropriate for criminal charges, then the referral goes into the Child Advocacy Center arena, where they would receive that assessment information. They could then provide case management for that family. If they have the therapists on site, they could do clinical assessment and possibly treatment. If they don't have it on site, hopefully they, as a community agency, would know where in their community to send children. And then CPS is kind of that safety net that actually treatment is followed through. The family does stay engaged. And then if they do not, a CHINS petition would be filed, which would loop them back into the court system to kind of be there to put teeth into the treatment and make sure that the kids and families were following through as needed. Because the CAC alone is not going to want to be kind of the place where there is accountability, so to speak, in the sense of if the family doesn't follow through, the CAC is not going to want to say, well, you have bad consequences, which is where CPS would kind of be that underpin to take the thing back into the court system. Again, not for punitive purposes of punishment of criminal charges, but to make sure our family and our children are staying engaged. Last slide, closing thoughts. We have good reason to be invested in the solution. There's high stakes when we're not invested, in the sense that problematic sexual behavior that's not treated does have bad long-term consequences. The great news is when it is treated, there's good outcomes for the community. And so intervention in this situation is prevention, but remaining neutral or not intervening does more harm than good. So in the big picture, there's a lot of motivation for communities and our state to invest in this solution. So it's a lot of information in a very short period of time, but I'm anxious to hear your thoughts and glad to answer questions.
Hey, Nancy.
Yes.
So first of all, I appreciate, actually, I thought this was really well done. Very easy to understand. I know there was a lot of hard work put into this. Very comprehensive. I love how you broke everything down for us. I have so many thoughts, as you can only imagine at this point.
Shannon, can I,
yeah,
just for the group, can you please introduce yourself so folks know who you are and the perspective you're coming from?
of course. I'm so sorry. Yes. Hello, everybody. I'm Shannon Hartung. I'm the Protection Program Manager at the Virginia Department of Social Services. So I do indeed oversee everything related to Child Protective Services. So I apologize for that, Nicole. I was thinking it was our regular group. I totally forgot we had new folks on. But anyways, Nancy, I think this was really well done. I really appreciate the work that you've done. I always enjoy listening to you anyways, because I think you're so terribly easy to understand. I have lots of thoughts, just a couple of things that come off the top of my head, and I know we're not even anywhere near there. I would like to see, at least from our, there's a couple of things. First of all, as you mentioned, we are not tracking specifically child on child. So I was just messaging Nicole, who's my policy specialist, who's also on this call. How many referrals, how many more referrals do you think this would be for us in a year? We have no idea, right? It's hard to even guesstimate that. And then, like you said, hi, Tracy. Tracy, who is our Assistant Director for Protection Prevention for VDSS, just popped on. So we have no idea how to even figure that piece out. And like you mentioned too, Nancy, you've got it all. We are having humongous staffing shortages already, workforce issues across the state. So that, of course, worries me, right? Not that we don't want to help and that we understand that this is a problem, but how do we get there? How do we get there with all these other factors? So I was thinking about that as you were talking. I was also thinking that and I think you didn't mention it, but I think I read it when I was looking through your document that I kind of think of this almost like our human trafficking assessment. So for those that don't know, several years, I feel like it was just last year, but I think it's been at least 3 years that we had legislation come through in regards to CPS had to respond to um, referrals regarding or allegations of human trafficking. So we created a human trafficking assessment. But that really it's CPS but it's really a prevention response.
Right.
So my point of all of this is when I was listening to you talk, and I know Nicole and I have talked about this, is I would love to see this come from that view, right? Because like you said, Nancy, and you said it, we don't want this to be punitive. Like that's not what we're in business for. That's not what none of us are in business. Well, maybe some, but we're not in business for that, right?
Right.
So I would almost love to see this come from that approach of prevention. How can we quickly get in there, work with that family, provide services, and engage that family to ensure, like you said, that this kiddo can stay within his home or her home and within their home environment, but making sure they're safe and the other children within that home are safe.
Right.
So that's really what we've been, and this has been a conversation for years as well, not just with you guys and with FACT, but within our agency. And I also loved how you said it really needs to be a community response, right? It's not just DSS, it's not just the courts, it's not just CAC for sure. How can we all come together? And I really appreciate FACT seeing that broadly as this big umbrella that we all need to be a part of. And I appreciate that we're finally seeing movement on that, Nicole Pullen, that we're finally seeing that we're getting somewhere with it. So for me, this is really super exciting. From the when I put my CPS hat on, I'm like, ooh, I don't know if it's CPS investigation. I'm thinking more that prevention response, which I think we've talked about too. At least I've talked with you guys about. But I'm sure others have thoughts. But those were just some of my initial thoughts as you were going through it all, Nancy. But I appreciate you. I appreciate the work you do. Really, really well done.
I'm glad you're still talking to me, Shannon, after making that proposal. I was worried for a while. And you're right. I do mention the human trafficking assessment in there, and I did make a connection to that as well. And I agree with everything you just said, to be in line with what I had thought as well.
Are there other questions? Cindy?
I'm a brand new FACT board member. I too want to commend you for a very thorough report. You have, I guess, having read the executive summary where you had recommendations of a number of, I guess, 7 or 8 items. The first one was forming, I guess it was forming task force. And I do not know what type of backgrounds of people, obviously, CAC, CPS, those folks, but I don't know if superintendents of elementary school be perhaps one of those folks who should be in that task force. You could divide the state to 3 regions: superintendent of elementary school, superintendent representing Northern Virginia or Central, and then rural. And perhaps include those folks to be part of the task force. Just a thought.
I think that's a great idea. I also think you said something that I think would be very valuable if that is something that's done, is that we make sure we have that geographic diversity representation, because one thing I did consistently see is, and no surprise here, more resources, more solutions, more things for that community as it stands today. Less resources, those communities are really, really struggling. And so we need to make sure we're getting both of those voices at the table, or all of those voices, I should say.
Nicole, Nancy, can I ask a question?
Please.
Nancy, Hi, Nancy. My name's Linda Wilkinson, and I am also a member of the FACT board with Cindy. Thank you very much for that very thorough presentation. I happen to be one of the lay people who I think Nicole made reference to earlier. So I appreciate the way that you've explained this. Very, very thorough. I'm curious if there is a DSM-5 diagnosis code for this, and I'm asking for a specific reason because there's some funding that is coming from the state that could, I'm wondering if it wouldn't possibly be able to help with at least the trainer piece when you're talking about training. I think your slide said training healthcare providers or providers in maybe more global.
I'm trying to think if I said healthcare providers, because that would be,
It might,
So can I I actually happened to listen to a lecture yesterday on this topic. And I'm not a clinician by training, but it was provided by clinicians. And from what I understand from this trainer from Oklahoma, it's the Center for Child Abuse and Neglect, University of Oklahoma Health Services is kind of a national leader on this work, is that it's actually not a diagnosis, it's a behavior that's exhibited, which I didn't know, but that answers your question directly. And that was a great coincidence that I happened to hear that yesterday. So
yeah, and the reason I hesitated too was that I don't know, and if I did, maybe I forget things a lot these days. I didn't in any way want to say that kind of my focus wasn't training those healthcare providers in the sense of the people who are ultimately going to treat these young people. But definitely for those people, anyone who would be screening these children in a different direction, and not understanding exactly what Nicole said, that this is a behavior issue. And what was and brought home to me, and I had heard it before, but it wasn't until I really lived in this for a few months, is that we should be looking at this as, challenging behavior a child exhibits, just as if they were hitting kids or they were acting out in other ways. Because it's sexual in nature, we look through that lens first. I think if you're not trained, and that should be really not how we're looking. We shouldn't be looking this as a sexually driven behavior. It's a behavior that has to be there has to be intervention. It just happens to be through a sexual acting out. And I think that for me is something that I know my colleagues in the criminal justice community, we are so trained to protect people from sexual predators that was really hard to separate that out and just say, we really could call this problematic behavior. And then in some little footnote, in this case, for this child, it was an acting out sexually or something, it's just not. And that's, I guess, what my big education thought is if there is a healthcare component for this, because I truly don't know if it's the same level of misunderstanding among healthcare providers as it is in the criminal justice community and the law enforcement community and our other community partners where people are making referrals for these cases. So I don't know, maybe someone else maybe Nicole, I don't know that.
I don't know that, but I think that what I want to just echo what you said, because I had a lot of misunderstanding about this topic when we started this project as well. And I remember a therapist who is a treatment provider for these kids said, when people ask me, what do I do if I see this type of behavior, on the playground? And his response was, what would you do if you saw the child shove the other child? Like, you take their Xbox away, like do the same types of repercussions for this type of behavior as you would with any other negative behavior. And that was, to echo Nancy's point, that was different than my entire kind of perspective of this issue. So it's been a learning opportunity. I did want to just pose a question that's in the chat that Ali Farouk from Families Forward. Ali, do you want to speak, or would you like for me to read your questions?
Yes, I would just, this is Ali Farouk from Families Forward, and I would just say, I was curious. First, yes, it was an excellent presentation. Really, really, really appreciated it. And really great suggestions. Honestly, I've been in a million of these meetings where some consultant comes up with research, and this might be the best one out of 13 years of public health experience.
Thank you.
So my very simple but very loaded question is, in any of your research, did you come across any programs that provided better comprehensive sort of sex ed or healthy relationship education for children and youth? Because I've seen and heard all the comments about how this is not a diagnosis, it's a behavior, then I would think that education and engagement on that, like you have to teach them, right? You have to teach kids what to do with these feelings and these ideas and these thoughts.
Yes, so in that full document, there is some information about kind of what is emerging as the best models. And I kind of broke it into two things. One, there's some evidence-based treatment models that are being used, and then there are also some teaching parts that should be part of any education. So, there's some things that if you're going to do it from an education perspective that need to be included. And then if you're going to do it as a treatment model, there are certain ones that are emerging as the best practice. And again, then this is just where, one, beyond the scope of the project, but two, beyond the scope of my background, not something I feel very comfortable talking about in any depth, other than to just tell you that, yes, I did come across some, and at least point it, I think in the document, point people to them to then learn about them themselves. Because especially with the treatment models, if I start talking about them in any depth, it won't be anything as clear as what I did the first part of this conversation. So yes.
We can, I came across some great resources from the Department of Justice. They've done some funding for trainings around this through their Office of Juvenile Justice and Delinquency Prevention. And they've worked with the folks in Oklahoma. And one of the trainings available is, and Nancy, I don't know if you came across some of their work. But one of the trainings is actually talking with parents about just normal sexual development in children, because it's confusing and people don't know, what's normal behavior developmentally for children. And there can be a certain level of, overreaction and, it's just really normal behavior, which can actually then backfire and have negative consequence and developmental issues. So they have some great training. We're going to make sure that gets on our website, and we can send it out to the group, just a link to the information if y'all are interested, because I found that really helpful.
Yeah, and I think that goes back to that foundational principle of everybody has to understand what problematic sexual behavior is before we can even appropriately respond to it. And I think you're absolutely right that there's a lot of misconception out there before we ever get into that. When we do need to respond to the PSB, we have a lot of people that think they have children with PSB that they do not. So.
Right, and it's a spectrum disorder behavior, right? I mean, all sexual assault, all abuse is spectrum behavior. So there's, most of the cases are kind of in the middle of kind of the least amount of harm and the greatest harm. There are, of course, on that spectrum, there are behaviors that are just kind of in that gray area. And then there are behaviors that are super duper harmful and, violent. And most cases with regard to most abuse and neglect, even within any kind of personal relationship, are kind of in that middle ground. So I think that's an important point to remember too, that because there was like a really egregious story in the news a few weeks ago, and that's not the majority of these cases, but that does exist. So I just wanted to make sure we point that out. And Nicole Ship just put, and when Shannon referenced Nicole, it was another Nicole. It was Nicole Ship. She just put some resources on from the National Center for Sexual Behavior of Youth, which is a wonderful program that CDC actually supports. And I know, thanks, Kristen, from the Sexual and Domestic Violence Action Alliance, just put some resources. Prevent Child Abuse Vermont has some phenomenal trainings that I would highly recommend folks check those out. And that we can actually put the links to some of that. And if you haven't signed up for their newsletter, you may want to do that, because they have like great trainings on a variety of different issues related to child abuse and neglect.
And Nicole, in the resources references in this, there, I think those are listed, and then the military has one as well. And I can't think of it at the top of my head, but there's another training.
Yeah, the military is actually the one that DOJ, Department of Justice, is contracting with this military counseling type of service to do the trainings. Because I was trying to figure that out, that relationship yesterday, but yeah, so it's great. We'll make sure these resources again on our website and we'll send them out to the folks here. Nancy, can we send your slides out? Are you okay with that?
Yeah, absolutely.
Do we have any other questions, last questions or comments anyone would like to make?
Nicole, one clarifying question. Nancy, in one of your earlier slides, did you reference a specific state that's sort of at the head of everybody else? Did you already say that? And was it Vermont?
Vermont is definitely promoting a lot of training of providers to give treatment. Missouri is the state that has their child protective services do the state or do all of the assessments, and they're the agency where any referrals when these cases are reported, they go into their child protective services. So I did specifically mention Missouri, but Vermont is, when it comes to the treatment component and trying to get providers and therapists and enough resources, they're doing a tremendous job.
Fantastic. And the hybrid model, I was really very intrigued by that. The hybrid model, is that your own recommendation or is someone else using that hybrid model?
No, that's my own.
Okay, based on what we have going on here in Virginia and okay.
Yeah, it really was just based on my understanding of how we have our resources. One big reason too is because without CPS having that state control, I think that, and I don't know the likelihood of that changing. That changes us from Missouri significantly enough that I didn't feel like, okay, we can just say it's CPS is the best way to do it. The other thing too is that when you look at this where it's working, it's got to be organically driven from the community too. And you know, so yes, that was my own. I hesitated to do that because it's pretty, I guess, bold for someone to come and say my way's the best way. But I truly did that from a perspective of a Virginia, looking at what we have and kind of our structure.
And Virginia is unique as well in how we do funding for services for families and kids. We have Carol Wilson here from Child Services Act. Virginia is the only state in the country that has this kind of entity that's a meshing of what, like, it's a lot of different funding sources that go out to communities to work with families in the court system, so that, like, our funding is different than every other state. So I think there's a lot of benefit to kind of looking at a unique model for Virginia. And I know I slaughtered that, Carol, but that's a layman's analysis, right? It's a bunch of money that goes into a state agency.
That was fun.
Well, we're at 2:00, and I just want to thank you all again for having an interest in this and caring about this. And I hope that this is just the beginning of this work in Virginia. And I want to be the last person to say, Nancy, you're awesome. And we are so, so lucky to have you. And I hope that we can continue working with you on this issue. Jenny, how are you raising your hand?
No, I'm just high-fiving.
Oh,
Yeah.
High
I like that.
five. Okay.
Well, I hope everyone has a wonderful weekend. I appreciate
Thank
it.
you all so much.
I appreciate being
And
asked
I
to do this.
apologize for technical challenges. I really appreciate everyone's patience.
Yes.
You did great, Nicole. Great.
Even though I was in fail, Jenny.
Thank you.
See y'all later. Have a great weekend, everyone. Thank you, Nancy.
Thanks,
All
Nancy.
right. Bye-bye.